Good afternoon. Welcome to the 6th Bright Blue event at this year's Conservative Party conference, when we will be discussing the challenges of financing care after COVID. I'm Diane Banks. I'm a non-executive director of Bright Blue, for which those who aren't familiar with the organisation is an independent think tank and pressure group for liberal conservatism. We focus on domestic, social, educational and environmental policy. So we have just launched a new magazine for this party conference, which examines the impact of COVID-19 on our lives. And you can read that online on our website, so please do look that up. And we will be having a major relaunch this autumn under our new chair, Sarah Sands. It'll be a great programme of events and new policy areas, etc., etc. So do stay in touch with us. Meanwhile, this afternoon's panel is held in partnership with MHA, and MHA are the UK's largest charity care provider. They have over 75 years' experience in care homes, schemes and community services across the UK, so they're going to be very well placed to add to the debate today. So a little bit of housekeeping. Feel free to tweet. In fact, we would love you to tweet using the hashtags at hashtag Bright Blue and hashtag CPC2020. And our handles are at We Are Bright Blue and at Your MHA. Okay, so we have 5 panelists joining us today, and I'm just going to do a little introduction to all of them. So, first of all, the Right Honourable Damian Green MP is the former First Secretary of State Minister to the Cabinet Office. He is the Conservative MP for Ashford, and he's been an MP since 1997. Sam Monaghan is the Chief Executive of MHA. Previously, he was appointed as Executive Director, UK Children's Services at Barnardo's. Anna Dixon is the Chief Executive of the Centre for Ageing Better. Previously, she was Director of Strategy and Chief Analyst at the Department of Health and Social Care. And she just has a book out, just came out in June, Age of Ageing Better. David Halpern is the Director of Behavioural Insights Team, otherwise known as the Nudge Unit. Prior to this, he was the first research director of the Institute for Government, and between 2001 and 2007, he was, of course, chief analyst at the Prime Minister's Strategy Unit, and he has several books out over the years, as you probably know. And finally, Councillor James Jamieson is chair of the Local Government Association. So today, each of our panelists is going to speak for 5 minutes, and then we'll have about half an hour for questions, which you can submit via Slido. We are going to be talking about how the costs of social care can be spread between the state and the individual, what we can learn from other countries' social care finance models. Does improving financial financing of social care require greater powers and freedom for local authorities, or is there a need for greater centralisation? Has the COVID-19 pandemic shown that social care system needs better integration with the NHS? How can we ensure that the social care financing is fair for both low-income and high-income individuals? And will the government's attempts at finding a cross-party solution for the future of financing social care be successful? Right, so I'm going to ask Damian to speak first, so that'll be 5 minutes, starting from now.
Thank you. With 6 meaty questions in 5 minutes. So good afternoon, everyone who is on this meeting. I think the first question to answer is, why has it been so difficult? We've known this has been a problem for decades. Other countries, like Germany and Japan, have set up systems that seem to fund it more sensibly than we do, and certainly better than we do. Why is it so difficult for politicians to grasp it? The first problem is most people live with an illusion that it's free, that somehow care is all part of the NHS. And also on top of that, they don't like to think about it because they don't like to think about getting old and frail. And politicians don't like to challenge illusions. And because it's going to cost more for all of us one way or another, then we need to cast away those illusions. And the problems of the sector are largely all symptoms of underfunding: low-paid staff, over-dependent on immigrant staff. The provision itself in some cases is on the edge. There's not enough of it. We've got private payers subsidising those who are funded by local authorities, and domiciliary care workers given impossible schedules. And also we should forget this is not just a problem for older people. Actually, the fastest growing demand for social care is of working age people. So how can we do it differently and answer the questions that Diane asked? The first thing I think is that trying to fund it out of local authorities is going to destroy local authorities. They will become social care providers and nothing else. So although it should be organised at a local level, I think it should be funded through national taxation. But I don't think that the simple solution, which is call it part of the NHS, nationalise it, fund it out of general taxation, works, not just because it would become the Cinderella service inside the NHS, but because it would be fundamentally unfair to younger people, by which I mean any working age people paying taxes. If you fund it all out of general taxation, then that generation or those generations not only pay for their own social care, but will also have to pay for the social care of those who are currently over 65, who happen to be a generation, 2/3 of whom have a huge amount of wealth in their homes. There's £1.7 trillion worth of free equity in houses owned by the over 65s. A sliver of that would help them, would help solve the funding crisis. How you get that money out of them in the fairest possible way, my suggestion is that we should use the analogy of the pension system, where we have a state pension, which has gone up quite a lot in recent years, thanks to the triple lock, and that should be, the analogy of that should be a universal care obligation or entitlement, which the state promises everyone, even if they can't afford any private savings, a better level of care than is often available now. But on top of that, just as with the analogy with private pensions, we should have an insurance system that allows people to pay for complete peace of mind in their old age. They will get whatever choices they need, depending on how much they can afford to pay into the insurance system. So you get more money into the system, and individuals themselves feel that they're getting something for something. On top of that, I think we should do two other things that are really important. One is to provide far more retirement specialist housing. We've got about 1/10 of the level they have in some other advanced countries, and the more people can live in their own homes, then the happier they are and the less we end up spending on social care. And secondly, within the NHS itself, we need to have a much greater concentration on public health rather than simply curing. If we increase the public health budget consistently, then far more people would be able to live in their own homes for longer, would not be as frail, and would therefore not require as much social care. But we need to do all of that, and we need to do as much as possible quickly, because every year we delay, this problem gets more difficult to solve, gets more expensive to solve, and perhaps most importantly, leaves more people leading fairly miserable lives. So it is really urgent.
Thank you, Damian. And listen, hopefully COVID will accelerate the discussion. Sam.
Thank you, Diane, and thank you, Damian. Couldn't agree more. And thank you also to David, Anna and James for joining the Fringe meeting today. As Diane introduced, I'm the CEO of MHA, and we've got 90 care homes across the country, 70 retirement living settings, and over 60 community-based schemes supporting people, particularly to address issues of loneliness and isolation. And I'm going to talk really for my 5 minutes very much from the experience of the front line. We had a Fringe back in Manchester a year ago, where I was advocating for a bold settlement for adult social care, particularly for the care of the elderly. And I'm back again this year. And the issues are the same, very much as outlined by Damian, but the timing could not be more imperative and critical in terms of what we're doing. We are facing into a second wave of COVID, and the first wave has been so utterly devastating. There has been a considerable and huge loss of life during the early part of the pandemic, but also what it has exposed is the lack of coherence, the lack of real understanding of what social care is about, and about the lack of investment as well. What the pandemic has also shown, though, is it's really shone a spotlight on the quality and calibre of the people who are working in the sector. Words traded around in previous times about this is a low-skilled sector have been shown to be utterly shameful in terms of what these people have been. And if we were outside clapping and applauding our carers during the course of the pandemic, well, now is a time when that needs to be put into action. And my first point really is in relation to that workforce. Adult social care, elderly social care doesn't happen without the army of carers. In MHA alone, we have 7,000 carers and 4,000 volunteers. These people provide extensive personal care and support, and they live with their residents. They take care of them on a day-to-day basis. And we do not remunerate them, and we do not provide a workforce strategy that properly recognises their need. So we need better training, better accreditation. We need a proper remuneration strategy. MHA are proud to pay our workforce the real living wage. We're one of the few organisations that do. However, it's not enough for what these people are doing, and that is one of the most considerable components of cost when it comes to talking about the cost of care. The other elements that we need to see in terms of the changes are proper investment in relation to the sector. Investment so that we can maintain quality, sustainability, and also continue to develop innovative practice. And it's not only in the care sector, but also in terms of retirement living, as Damian said, and into our community services, because we've got a more robust infrastructure out in those less dependent services, then you are able to better meet the need across the whole piece. And I think the final thing to say is that what we really need is a shift in understanding around our elderly in this country. I watched a really interesting programme on Harold Shipman. Some of you may have seen it this week in terms of an analysis of what happened in terms of the number of people who he killed. And one of the findings at the end was actually part of the reason he got away with it was because it was older people, and older people have a tendency to become invisible and their needs not to be seen in the same way. And the same thing has happened really, I think, with COVID. It has, in a sense, finally brought to light the extent of the issues around social care. But this is a whole population. And our motto in MHA is live later life well. That's what we want to see happen, and that's why we need the investment. So thank you for everybody who has been tuning into this Fringe meeting, and please help us take this agenda forward. Thank you very much indeed.
Thank you, Sam. Some important points around the workforce in the care sector there, which I'm sure we'll pick up on later. Now I can move to Anna.
Hi, thanks very much. As was said, I'm Anna Dixon, Chief Executive of the Centre for Ageing Better. We are a charity with a very positive vision that we want to create a society in which everyone enjoys later life. And we do that by trying to influence policy and practice using evidence. And I've had the pleasure of leading the organisation for the past 5 years and have brought a lot of that evidence together in this book that I've written, The Age of Ageing Better. And in it I have a chapter on who cares. And I suppose it's a question, who does care? So at the moment it feels like politicians don't care enough about social care. And unfortunately, a lot of the care is falling to unpaid carers and family members. And so I think it's really important that we take this opportunity where we've really seen the huge and important role that carers play to actually address some of the problems in social care. But as an organisation, we focus really on trying to prevent people having poor outcomes in later life by focusing on people approaching later life. So perhaps not surprisingly, I'm going to focus a little bit on some of the actions that I think are needed for us to manage demand for social care in the future. I think it's really important we remind ourselves, first of all, what we're funding. It's very easy to get into technical debates about how to fund, how to raise the money and discussions about different options. I think it's really important to remind ourselves this is about care and support to enable people to live as full a life as possible, despite disability, whether that disability is something that they're living with during their adult life or into later life. I think it's really important as well that we remind ourselves that actually for the majority, for most of our later life, we actually won't have any care needs. So take the average 65-year-old man, we can expect to have another 17 and a half years of life. That's the sort of life expectancy for an average man aged 65. 11 of those will be completely independent, won't need any care and support. For 4 of those years on average, he'll need some sort of low-level support. That could be things like help with shopping or housework. For just 1 year, he'll need what's sort of been classified as medium dependency, things like occasional help or daily help with dressing, meals, etc. And that can often be and is provided in people's homes by what we might otherwise call domiciliary care or home care. And I think it's often overlooked and forgotten, or it's given by family members. And it's just 1 year when, on average, we have higher dependency towards the end of our life, where we might need more intensive 24/7 care. So that's what we're trying to fund. We're trying to support people through those latter years. The lack of funding, however, in recent years mean there's been massive unmet need. It's only really if you have that highest level of need towards the end of your life that care is provided. And really the rest of it has been a huge shift onto unpaid carers. There's already 1 in 5, 50 plus involved in care. We know that's gone up during the lockdown and during COVID. So it's vital that there's an increase in funding to address this gap. But it is also, as I started at the beginning, really important that we fund prevention. So 1 in 5 people over 85 have what's called sarcopenia, which means that they've got muscle wastage and loss and a very high risk of falls. And yet we know that that's reversible. With the right evidence-based strength and balance exercises, it's possible to, first of all, maintain that muscle, but also to regain it. And this so-called deconditioning can result in people simply not having to get up and go to cross the room and go to the toilet. And that's the difference between being able to stay at home with occasional care and needing that 24/7 care. So let's get the evidence base around prevention in terms of strength and balance. And then secondly, on housing, which I think Damian mentioned, at the moment, only 7% of our homes are even just visitable by somebody with a mobility issue, not able to stay overnight or live in. And so it's incredibly cost effective to adapt homes. And wouldn't it be great if we actually built our homes to higher accessibility standards so that they could meet the future needs? But too many people are waiting too long for those adaptations at the moment. So again, it's really important that we're not funding just the care, but we're also funding these very cost effective housing adaptations. So in conclusion, I think it's really critical that we properly fund social care. We recognise the burden that is currently being met by unpaid family carers and support them, and take these actions to prevent through physical activity and through housing adaptation to try and reduce that future demand. Otherwise, we really aren't going to be able to afford social care. And those family carers, they won't either be able to carry on working, and that will have economic consequences. So I think, as well as looking at the technical issues about funding, we just need to remind ourselves how we can fund things that will also prevent the need for social care.
Thank you, Anna. And prevention, of course, is a very important element to all of this, which I'm sure we'll come back to. Just before we go on, just a quick reminder to everybody watching and listening, please do keep those questions coming through via Slido. Okay, going to move to you now, David.
Thank you. Thank you very much. I do actually commend, by the way, Anna's book. I've got it right here. I was using it to crypt some stats, actually, just remind myself, not least about the German system before. Some quick remarks, like something about, asked about COVID, thought about funding, operation, and then finally, what's our real ambition for this whole show in my 5 minutes. I mean, on COVID, I think, look, obviously it's highlighted, and Sam was certainly, I think he's right, clearly has brought profile to the sector in an unfortunate way in lots of ways, but maybe made people more aware about it and the extraordinary thing that many people who work in the sector, both the numbers, but also the role that they play. I do hope the lessons are, however, are, they're not simple ones. our vision surely of social care is not going to be one about shielding and even cocooning our old people. If that's what we figured out how to do, rather important that we need to do that and do it better. But in the end, that's not a long-term model, surely, I think, for what we want for our social care system. So definitely some lessons, but also some things not to get drawn into and just think, well, that's how the system should be. Also, not to think it's all biochemical. And there's Anna's example around balance exercise is actually being a very powerful intervention. So on funding, Damian, of course, put this beautifully at the beginning, but essentially boils down to most people don't even understand, or certainly, in fact, don't even think about the care system and how it funds, certainly in working life. Probably no more than half of people have thought about it at all, let alone thinking through its consequences. And typical estimates around 15% of people, no more than that, make any serious provision. So my view about it is there's been beautiful, elegant bits of work on it, not least by Andrew Dillnott and so on, about clever insurance systems. As a behavioural psychologist, I'm very sceptical about this because, as Damian laid out at the beginning, people actually aren't very attracted to the idea for the most part about thinking about, for example, as how Anna just put it out beautifully, about a kind of life expectancy, but also on that, remember, it will vary quite a lot in the different sort of stages. Most of us are going to assume that we're going to kind of carry on living forever and certainly be super fit and healthy. The idea, what do you mean I'm not going to live forever? It's not a very appealing psychological prospect, let alone the idea that you might want to insure against it. I think most of us are going to carry on. We'd rather just go on a state of denial, frankly. And that's about being human. And we can sort of try and wish that away. So essentially it takes you to most funding systems. You can see why most countries end up either with some mandatory insurance system or essentially some state pooling of the risk, which makes a lot of sense. I mean, the state is there to try and take on brute life risks. The final technical issue, I think, is that when you have a risk which is potentially brute luck in terms of some of the variability that is on average a year, but of course we know there's quite a bit of variability around that, you're playing certain kind of Russian roulette, which may be predictable, may become predictable, and actually it makes it quite hard for an insurance system to handle it. So I do think we have to do something pretty bold in it. I also think there's room to offer some reform around pensions, which gives you peace of mind around social care too. On operation, at least briefly, we haven't talked so much about it. I think there are a lot of nuts and bolts issues in the system which we surely want to get sorted out. But when people do need social care, I should say we did some work for the CMA on it, the Markets Authority. It's really hard to find out what's available, at what price. Try and search. You might have to go to homes in person. Do they even have availability? It's very hard to trawl through this. And that's particularly problematic if the only thing you can easily see is price. And even that, frankly, you can't see very easily. So it's what we have to call a shrouded market problem. You can't see the important variable, in particular the quality of care. And it seems to me this is something we ought to try and fix quite fast, not least for the sector itself, but the last thing it wants to be competing on is on the basis of price alone. So my own view is we should do a much better job of helping to collate, in fact, local authorities can play a big role in this, really good information, essentially versions of friends and family tests, where you can see good measures of quality. So you can get competition on the basis of quality, not just price, in a reliable way. Another small detail going to kind of the research side is that at the moment, I think I'm right, in the Digital Economy Act 2017 still ruled out the use of any kind of data from health and social care in order to collate and use information to try and do what Anna does better, which is to figure out what works and what marginal gain. So that's another issue we should try and get on and fix pretty fast if we can. The last thing, though, let me just what do we really want for this? A bigger question is clearly about more than funding, and what's our vision? So Camilla Cavendish, I think, has written beautifully about other kinds of systems, and it talks about some of those too. And I feel like we should be able to not just crack the funding issue, but think deeply about how do we want society to be. There's some beautiful schemes, in my view, across the world, which actually kind of draw on the capabilities of older people much better. I love the Japanese Furukipu, the care tickets, where people are able to essentially care for others, or indeed for other elderly. If your mother's too far away to care for, but you can care for someone else who's elderly, and you get these kind of credits. It's actually not volunteering, it's reciprocity. It's a really lovely thing to do to try and catalyze that ability to help each other, I think. And so I think there's lots of schemes like that. There's a beautiful scheme in Baltimore where older people go in cohorts of schools and they actually feed young people. So there's lots of these things. I would just say, I think our ambition should not only be a well and adequately funded system, but also it does raise more deep questions about how do we want our society to kind of operate. So a great topic, and I'm glad we're talking about it today.
Okay, thank you very much, David. And now I'm going to move to James.
Thank you, and some really good insights there. And I think it does come down fundamentally to two issues. One is money. How do you fund it? But actually, have we got the right model? And I think several comments by Damian, David, and Anna that maybe we don't have the right model anyway. But if I come on first, I'm very pleased to represent local government because we do fund and we are involved very heavily in social care. And I think this COVID epidemic has just demonstrated how important and how vital it is and the role of carers in keeping some of the most vulnerable alive. And people have begun to appreciate them. And I think one of the biggest issues that we have is I don't think social care is appreciated enough by the public. And one of the things we would ask for is parity with the NHS from a public sector perspective, that people think of social care in the same light when it comes to funding and process as they think of the NHS. And in that way, we may actually get more money on social care and we may do more prevention, which means fewer people will end up in hospitals. And I think that's important because this crisis has exacerbated the pressure on local government funding social care. If you go back a decade or two, and around 50% of local government funding was spent on adult and children's social care. It's now 70%. That is very significant. We cannot afford local government to just become an arm of social care because we need to do so much more, and we won't do our role in terms of our communities and prevention. So I do think we need funding, and we need funding that is linked to need, not to business rates or council tax. And Damian has done some very good work looking at various insurance-backed schemes, a minimum income level. You mentioned taking out of property. I think there's many models, but we need politically to accept that funding needs to happen, and then we need to accept that it needs to be cross-party, and we cannot afford for any party then to use it for political purposes. We all know Theresa May's election when the death tax was mentioned. That killed the idea of trying to find sustainable funding because it was too difficult. And if we could have a bit of neutrality amongst political parties to just say, we know this needs to be done, and it will inevitably require some compromises and some decisions that the public may find difficult because, as has been said, nobody wants to face the reality that they may have to pay for their old age. So I think that's really important. I think the recognition of the care sector is really important, and the recognition of the level of funding. It is underfunded now, and it's only going to get worse because as we all get older, the demands will be greater. And if we're going to do, as Anna said, pay our care workers appropriately, that will exacerbate the funding. We're trying to do it on the cheap, and we can't. But I also think we need to change the way that we do it. We do need integration with the NHS, but it needs to be led by local government and by communities, not by the NHS. If it's led by the NHS, which has a health focus and a hospital focus, it doesn't have a care and prevention focus. But we need that integration. We need to spend more money on prevention. As Anna was talking about, the idea of deconditioning, tremendous things that you can do by improving people's health, using occupational therapists, getting people to have better diet. I think one of the other big issues is loneliness. How do we avoid loneliness? And actually, there's a lot of lonely old people. So how do we create networks when they can help each other? And that's actually about housing, and it's about communities. How do we create communities? And it's not just about having accessible housing, it's about having the right mix of housing in the right places. And I know locally we've been building some extra care facilities and some care facilities. And a quantum change in the life of people who've done that. And I'll give the example of Jim, who moved into one of our facilities at 90. And he had 2 birthday cards on his 90th birthday from his 2 sons. On his 91st, he had 48 birthday cards. His life had been transformed. He was no longer lonely. He met met a number of people every day for coffee. And his health improved dramatically. We need things like that if we're going to change. And we need to take the NHS out of the hospital and into the care home or into the community, because actually old people don't want to go to hospital. They want to have a healthy life. And actually, as Anna was saying, that 11.5 years of of life where you don't need intervention? Can we extend that to 12 or 13 or 14? That must be our target. And the LGA, just to get the plug in, has launched its 7 principles of older living and social care. And I really would urge people to look at that, because we can do it differently. And it's got to be based on local, community and joined up services that are adequately funded. Thank you.
Thank you. Thank you very much, James. Love the story about the birthday cards. That's an optimistic way to start our Q&A session. So there are a number of issues that came up there. So generational issues, integration with pension, housing, workforce, and our appreciation for the workforce. Prevention, I thought, was a key point that Anna was making there. Quality versus price, looking at visions for an ageing society around the world and seeing what we can learn from other countries. The split of funding and engendering a sense of community generally. Now, I've got a few questions coming in. Just to say, if anybody is having trouble with Slido, you can also ask a question on Twitter with just use the hashtag #BrightBlue. I'm going to jump in and ask the first question. So the title of this panel is Care After COVID specifically. So I'd love to go around and ask the panel whether your thinking around how to approach the crisis has changed at all throughout the pandemic, since the start of the pandemic earlier this year. And I'm going to start with Anna.
Thanks very much, Diane. So I think, it's been said, a lot of this was invisible to everyone apart from those that had loved ones who were needing care, where they were more than acutely aware of the difficulties of getting access and support. But for many people, this was invisible. And I think what COVID has really shown is that invisibility and that lack of recognition of both care being delivered in care homes, but also the acuity of people who were being cared for in their own homes, meant that the action was far too little too late in terms of protecting people and a lot of the preparation that went in and rapid response to the NHS just wasn't followed through with care. And it's a pity when the title of the Department of Health changed to Department of Health and Social Care. It was thought that really would give it its parity, and it hasn't. But that visibility now, I think we can't go back to a denial, and we must use this as an opportunity to take action. So I think that is really the opportunity post-COVID. And I suppose the other thing that has changed is that the sort of lower level community support. So there's been huge mobilisation. Some of the communities that we're in touch with across the UK network of age-friendly communities, over 40 local authorities and members, covering some 21 million people across the UK. They've done an amazing job. Local authorities working with the voluntary sector, working with local neighbourhood groups to really mobilise and make sure that everybody has that basic level of support that they really needed during lockdown for medicines, for food. And so we really hope that some of that cooperation, some of that shared data, some of the identification of people in need that were just not known to services before, and new volunteers coming forward to help, that can also be built on as a positive basis for some more of this sort of asset-based community sort of approach to care and support.
Yeah, absolutely. Sam? Oh, I think your one might be on mute, Sam.
With the programme.
Oh, again.
Yeah, two highlight issues for me is community and digital. In terms of community, we were already moving to try and bring the community more into our facilities and working, and build those links in terms of the clarity and the quality of life, particularly around things like intergenerational work with local schools, play groups, with local community groups, to really try and foster that. And I think there is an even greater imperative to do that. And I think with the window that COVID has provided, we will have more armoury, if you like, in terms of that. The other element for me is digital. And what we've seen is we've transferred so many of our community services into digital because we've not been able to reach people in person. And that has demonstrated the fallacy that the older generation are not so tech savvy. and that they can't adapt to that. So in community services, the use of digital to decrease elements of loneliness and isolation, it can't replace the personal interaction. But also then in our homes, the increased usage of technology to help families retain contact, because that's been one of the other huge losses, is the fact that people have not been able to see their loved ones. And we need to find ways of sustaining that. But I think there are shifts that we would not have drifted towards as quickly as we will do now that we've had COVID.
Damian?
I think the wider sort of political change has simply been a raising of consciousness, really. David sort of made the point that, as I did, that by and large people don't want to think about being old, getting old, particularly not being old and frail. Well, when we had that terrible period where the deaths from COVID appeared to be concentrated in care homes, that had the whole country concentrating on it, and therefore added pressure to thinking that we need to do something radically different, because this system is clearly not very resilient apart from anything else. So that's one change. I think the other change, as it were, means that although it's now more accepted that we need radical change, it also just means that radical change is going to take a bit longer. We've already had Lord Bethell in the House of Lords saying that the government is not going to come up with a new policy this year, and so I hope we're going to get it early next year. But it's understandable, and to point Anna made, we now have a Department of Health and Social Care. Well, in the middle of the biggest global pandemic for a century, that's what they're going to concentrate on. So a big, difficult, long-term change like this inevitably has gone back a few months. I think internally, I'd very much take the point Sam makes that, and I think it's not just in social care and health generally, this will massively accelerate the change towards more digital diagnosis, contact, communication, and so on, which is a very good thing, and will actually mean technology is used much more in this sector than it has been in the past. So that will be one positive that comes out of it.
Yeah, absolutely. James?
Yes, without repeating what everyone else said, definitely technology. I think also it has highlighted the area. I think the quite interesting one is the health service has started to change. You don't need to go to your GP anymore, and that's actually been quite useful for a lot of older people, being able to stay in their homes and getting a digital consultation, or actually, shock horror, having somebody turn up from the health service. So those are good things. But actually, the other thing is it has exacerbated the financial crunch that the sector finds itself in. The costs have gone up with extra PPE and so forth, but actually we've only got temporary one-off funding so far. So there's a really big danger as we come into next year that we could find ourselves in an extreme financial crunch. And that's something that government really needs to take very, very seriously. Even before there is a long-term solution, there is an immediate need for the back end of this year and next year.
Thank you. And David, anything on the behavioural side of things?
Sure, a little bit. Clearly what I think behaviour, not least of officials, is to make you realise, like many people in the HSC, they didn't understand the system as well as they thought they did. How actually workers are deployed, in what way, how do you provide benefits or support, how it flows through the system. So it was a pretty big wake-up call, I think, for some people to realise, God, we don't even understand the system well enough. The digital is definitely not digital. As James was saying, it's also, I think, that it's a way of getting care in different kinds of ways. If I had to choose one thing, which is maybe behavioural, I don't know, is it behavioural or just even understanding the humanity of it? It's not just the headline numbers, of course, that increase because of COVID, but maybe reminding some people around the actual humanity, how important it is. Because COVID, that's probably so cruel about it, right? Is it essentially spreads through social networks. It spreads through social contact, and yet social contact is so precious to us always, but particularly later in life.
Yeah.
So you would see this not only in terms of the primary COVID deaths, but also, as much commented on, patients with dementia, who they just have less social contact and they just sort of give up. There's an old Nordic study which shows if you have a meal once a day with someone else later in life, it gives you an extra 2 years on your life. We are phenomenally social creatures. So if it gives us a jolt, like actually, reality behind it. Maybe we can try and figure out better ways of doing this. Although, as said, ironically, COVID itself has forced those barriers in, but maybe we'll see them, how precious it is essentially to have that social contact.
Absolutely. Just a quick reminder, if you're sending questions through Slido, the code is C381. Please also do feel free to send them through via Twitter. Okay, so we've got a lot of questions coming in. The first one I'm going to take is from Eric Donner. Should we increase taxation on baby boomers to fund their social care? And I'm going to ask that one to Damian.
Well, I don't think we should. You say increase taxation on baby boomers. Most baby boomers now are pensioners. So if you wanted to say we're going to increase taxes on them, then good luck with winning the election after that. I would say if you're from a political background. But more to the point, I think what you should do, because as I said in my introductory remarks, 2/3 of that generation are actually wealthier than any previous generation. A much wider proportion of them have some wealth because of house price inflation over the past 30 years. So I think rather than tax them, it's much better to set up a system that will encourage them to think, I'm buying an insurance policy. This will give me complete peace of mind in old age if I need it. I'm aware that if I buy this insurance policy, it might be a waste of time. But on the other hand, I buy car insurance every year, hoping it's a waste of money. I buy house insurance every year, hoping it's a waste of money because I don't claim on it. And I think there need to be technical changes. You need a sort of catastrophic stop loss policy so that if your policy becomes really expensive to maintain, if you're one of the relatively small number of people who need hugely expensive care for a number of years, that would have to be covered by the state. But with that and one or two other caveats, I think you can set up a market that enough people over 65 would pay for, which would get the fair contribution from baby boomers that otherwise you wouldn't get. Otherwise, if you do just do it on working age taxes, then one generation ends up paying both for their own social care and for their parents' generation social care, which seems to me to be unfair.
Yeah. Anyone else want to jump in on that one quickly? Anna?
Just very briefly, can we please tax wealth and income and not sort of tax by age? There's massive inequalities within generations. Even this caricature of the baby boomers, they're not all wealthy. So yeah, let's tax wealth and income. And also, let's just be clear, which I think David was saying, there's no suggestion that this is insurable on a private or voluntary basis risk. We're all in denial about it, all of the various things that have been said. If you don't want to call it a tax, then it's a mandatory social insurance. But I mean, at the end of the day, it needs to be mandatory.
Okay, right. So I'm going to move to the next question. This is from Andy Bevan. A lot of the compassionate social reforms that David mentioned have been mooted for years. Why hasn't government been motivated to pursue to pursue radical changes like these? David?
Well, it's days like this, I'm very glad I'm not a politician. I think we put it on governments and politicians, but it's really on us about our own denial. I was very struck I think it was the Ipsos Mori work, which was done with King's Fund and Health Foundation 2018. We asked people about what they kind of think, because they don't understand the system very well. As people understand the system, like they're done as deliberative forums, they're done as a sequence, some may know, the public actually become quite radical about the kind of reforms they want, and they describe the system as Anna has said. I do, myself, I've always been a big believer, I like deliberative forums, and I think it'd be quite nice to have a third chamber in Parliament, basically, where you could bring in a sample of the public, and where it's in the too difficult box, you say, you know what, you're not going to like any of the options, as we had to do on pensions. We can take a sample of the public, and we're going to get you to think it through, and then we're going to take that very seriously. Now, whether that's enough to create the space, I mean, Damian is the one who will know much better than me, to give license to government and politicians to do something which we all sort of know we need to do. I don't know. But it seems to me in the end, that's what we've got to do. It's not fair just to say it's politicians. We ourselves aren't prepared to bite the bullet. But, I think when people go through it, they do seem to. So can we do that to scale?
Anyone else want to jump in on that?
I suppose I'd just like to ask, and this is another one back to you, David, but given your work around behavioural sciences around nudging, how do we shift not only politicians, but then the whole of society in the direction where they sustain this understanding that they've had a glimpse of through COVID in terms of the older generation and the need, therefore, that there is to make provision for those and to structure society in a more equitable and fair way?
Well, it's probably not my job to nudge politicians. They're the ones who set the agenda, not people like me. But as I said, I do think there is this issue where we could strengthen our mechanisms which give permission to politicians to go further and faster. That's actually true for lots of public health issues, where the choices which we make collectively are different than the ones which we make individually. And can you catalyze that more strongly? There are more specific mechanisms, a famous one in the literature around, if you see a picture of yourself aged, you're prepared to put much more money into your pension. And particularly there's a beautiful study where as you put more money into the pot, you adjust the dial, your future self looks happier and happier. There may be ways of identifying with your future self as opposed to seeing this alien creature. But I said, I think that's kind of a prop or help, but there is a way of creating a public license, and that's why I would try and get behind.
Okay.
I mean, I do think, Diane, that if you talk to most politicians who study this and most experts who study this, there isn't a huge disagreement on what the solution is. There'll be subtle variations. The problem we all face is how do we make it popular with the public?
Yeah.
Because if it was popular with the public, the politicians would do it tomorrow.
Yeah.
But these are difficult decisions. They involve reducing the amount of money someone has today for sometime in the future when everyone is hoping that they will not need it anyway. And it's not an insignificant sum of money that you will do, but that's essentially what we need to do. And whether it's compulsory insurance or tax, or you have higher death duties or whatever, the mechanism is not the difficult bit. The difficult bit is getting the public to think it's a good idea.
Absolutely, and that leads in very nicely to the next question, which is anonymous. What time frame do you think is needed to move funding away from local authorities to avoid burdens on the current working age population? That's something you've spoken about, James, so I'm going to go back to you on that one.
I'd be careful this. I think local authorities are probably the best place to deliver the service. So actually the funding should come to local authorities. It's the tax raising bit that I think, or the fundraising that needs to come from a different source, and whether it's an insurance scheme or as I said, some variation on tax. I also think actually some of the money that goes to the NHS should come to local authorities, because then we'd invest it in prevention and overall the cost would be less.
Mm-hmm. Anyone else want to jump in on that?
Yeah, I'd rather agree with that. I think the closer to the local level you can actually organise the service, the better. But whether we have insurance compulsory or voluntary on top of taxation, we will need general taxation as a very large basis for the money going into social care. And it does seem to me that, frankly, the sooner we can move away to a national basis rather than a local basis for that, the better. And because we already have done in that the council tax that councils are charging for the past 3-4 years has had to be topped up by direct funding from the Treasury. I think we should just get honest about this and say there will be a sum of money every year that we can argue about, but that just comes out of general taxation. So if it keeps coming out of local taxes, then local government will quietly just become a social care service, as James said.
Yeah. Okay, that leads nicely on to a question from Ian Young. Should NHS and care services for the elderly be provided through community hubs? And which organisation should coordinate provision to individuals? I mean, it seems to me that there may be an issue. There's all sorts of wonderful organisations working in this space. Perhaps coordination is an issue. Anna, do you have thoughts on that?
Yeah, well, we've been trying lots of different approaches to integrated care for about, I was going to say the last 20 years between the NHS and social care. With mixed success, certainly some great examples around the country. I think the problem has been universalising this, that it's a general experience that most people, and there's so many barriers that get put in the way. Funding is part of it. You have a means test on the social care side. whereas, you know, care is obviously free at the point of need for the NHS. There is, you know, different professional approaches, and a lot of the time we seem to be responding with structural change, and we see that again with the NHS creating some integrated care systems. And I think there's no evidence internationally that those structural changes actually result in coordinated care for the individual. And I think we've got to really put all of our weight behind the personalisation agenda. It was there in the Care Act. It's called different things: north of the border, self-directed support, personal budgets, direct payments. But the idea basically that an individual, it's about what goals are they trying to achieve, what support do they need, and how can we commission or provide that care to meet those needs in the best and joined up way. And I do agree with James. You know, at the end of the day, whether it's an NHS pound or a local authority pound, we could spend it better if we actually just focused it around the coordinated needs of the individual. And so we've got some of the answers, but we just haven't followed through and made it the reality for everybody.
Yeah. Sam, did you have thoughts on that? You're on mute. Can't hear you. You're on mute.
Yeah, one of the things that COVID, I think, really writ large was when you're talking about the NHS, whether it's myth or reality, it seems a more coherent and cohesive setup. When you're talking about social care, it is so diffuse, even within the residential sector, let alone then when you talk about retirement living and around local community support services. I think out of that diffuse nature, you do get quite a lot of creativity. And I suppose what you need to do is try and find some way of that balance of maintaining that creativity with local providers who are joined up and working together and collaborative rather than in competition, but where then the community is benefiting from the mix of resources that are coming in. But there certainly needs to be a far more coordinated and coherent approach to how the funding takes place, because the other thing that this has shown very clearly is that local authorities, public health, have responded. We're a national organisation, England, Scotland and Wales. We had very different responses in different areas across the country, which as one organisation trying to work in all those areas was really, really problematic. So there's a huge piece of work to do about bringing greater coherence to all of this.
Mm-hmm. And James, you wanted to come in?
Yes, because I'm very biased to being local for obvious reasons. But ultimately, this is about a person and a community. And the closer you can get decision making to a person and a community, and I would say this is beyond the NHS and local councils. You know, this is also about education, it's about housing, it's about transport, it's about DWP, because we're not talking about how do we look after an 85-year-old. That may be today's concern, but actually it's how do we get a 40-year-old to make sure when they hit 85 in 40 years' time that they're fit and healthy and various other things. And that's about how do they get more exercise? How do they have a job? How do we have communities where you don't get social isolation because we don't design them as dormitory towns? We actually design them as proper communities. So the closer that you can knit all these things together, the better. And, you know, there is no way that from Whitehall you are going to make the right decisions from an individual who may be touched by 5 or different Whitehall departments, because it's too remote. It has to be done at a local level. Now, the problem with all of this is you will get, as Sam was just alluding to, a bit of a postcode lottery. You'll get different priorities and different strategies in different areas of the country. But that actually may be appropriate, because smoking may be a huge issue, and I've no idea, I don't wish to cast dispersions in Liverpool, but, you know, in another part of the country, it may be obesity. So that's where the focus is, and it will be different. And, you know, it is about joining up all services, not just the health service, at the local level over a long period of time. Because what we want to do is not just invest in 85-year-olds, we want to invest in people from zero to their death, and we want them to have the best life possible, which will also mean that they have the best retired life possible.
Mm-hmm. Great, thank you. Right, we've got time for one more question. This is from Anonymous. Do we need to rethink payments for carers? I nursed my wife for a year with her cancer, willingly, of course, but was told any carer's allowance would affect my pension. Damian.
It's an eternal one of how do you pay people for doing things they do out of love and would do anyway out of love? And the state can very easily appear very hard-hearted about this. I think the answer is basically sort of continuing to increase pensions. I'm one of those who has defended the triple lock in the past. So I think that's the long-term solution, because once you start paying people for caring for their immediate family members above and beyond what we do now, you can always increase the levels. But I think the system now is as coherent as you're going to get. If you try and do just simply to pay somebody as though they were coming in as an outside carer, then it would obviously be very, very expensive. And therefore what you'd end up doing, I suspect, is not paying enough to people who genuinely need it. And maybe paying too much to others. It would be quite messy.
Mm-hmm. Okay, Anna, and then we're going to have to wrap up.
Yeah, just briefly, I mean, I make the argument in the book that I think for working age carers who are not able to work because they are providing full-time care, carers' allowances are not enough to live off. And we need to make it an acceptable amount of money for people to not be living in poverty whilst they're caring for loved ones. And I think, I think it's really important that the system at the moment, unlike some other countries, is not carer blind. So if there is somebody there, even if that person's supposed to be working, the system will basically say, sorry, we're not providing you with any support. And I mean, we see examples of people providing very, very high levels of care that they do not want to. It's not voluntary. It's, they do love their loved ones, but they're doing more than they want because the system is so strapped. It is rationing on the basis of if there's somebody there. And we've got to get back to a system that is much more generous than that and providing appropriate levels of care. And therefore, it will be optional and voluntary for people to provide care over and above that.
Okay, thank you very much. That's all we've got time for today. An important issue that will affect all of us. Lots to go away and think about. So a big virtual round of applause for all of our panel, and a huge thank you to Sam and the MHA for partnering with us on this event. It's just flashed up on the screen. Please do join Bright Blue by going to our website onto the membership page and look out for the rest of our events that we've got running both at this conference and indeed thereafter. So a big thank you again to everybody who is listening at home, and hope to stay in touch with you all and see you all again soon.